Hi, good morning all. Sorry to encroach upon the break. I will try to make this quick. I was told to keep this basic, so my talk is going to emphasize on the basic principles of pre-transplant evaluation. The phase begins the moment you decide that you have exhausted all the medical and the surgical therapies for the child with heart failure. So you have to know the indications. It includes a gamut of tests to decide the candidacy. In the meanwhile, until the organ arrives, you have to keep the child stable, prevent end organ dysfunction. So prevent wait list deterioration and mortality, and definitely you have to help the family with the financial arrangements. So the goals of pre-transplant evaluation will include identifying factors which can lead to possible transplant failure. Now, these factors could be anatomical, hemodynamic, immunological, or infective. Thus, you have to sort of make a picture of the ideal donor organ which should suit your recipient. There is a list of indications which we all know, and I'm just going to brush through them. So stage D heart failure, which is refractory heart failure. A child is in cardiogenic shock who is dependent on inotropes and or devices. Complex CHDs with no further options of surgical repair. Unresectable tumors. Malignant arrhythmias, which is refractory to medical therapy. Low or diminishing VO2 levels in a child who is with chronic stable heart failure, and definitely excessive disability, poor quality of life due to recurrent admissions in view of failing myocardial function. Having said that, you have to remember that inability to achieve optimal medical therapy in view of progressive end organ dysfunction or hypotension also indicates poor reserve and forms an indication for transplantation. So Dr. Cantor has beautifully explained the stages of heart failure. It is important for us to identify a child when he is progressing into advanced failure. There are a lot of definitions, and the standard definition of advanced failure would include severe persistent symptoms, severe cardiac dysfunction, which would be defined by EF of less than 30%, isolated ventricular failures, non-operable severe valve abnormalities, non-operable CHDs, recurrent hospitalizations either for congestion or low cardiac output, and definitely deteriorating VO2 levels with a 6-minute walk distance of less than 300 meters or peak VO2 of less than 12 to 14. So it is important to identify these children who are progressing towards advanced failures and sort of the oral therapies have started failing. When not to wait? Do we really wait for this subset to progress into advanced failure? So there are certain conditions where we wouldn't want to wait. So restricted or hypertrophic cardiomyopathies with the first episode of heart failure itself, ischemic cardiomyopathies, uh, CTGAs with ventricular dysfunctions and severe AV valve regurgitations, surgically exhausted conditions, and a family with a proven genetic cause for cardiomyopathy with a previous death. What are the contraindications? Fixed pH. A cutoff of 6 has been used by most of the centers. However, we are slowly moving towards 9 as per the newer studies which have come up from 2015 onwards, which have demonstrated that a pH of 6, between 6 to 9 would be borderline, and up to 9 could be manageable. Uh, all anatomical causes which could preclude anastomosis between a donor and a recipient organ, such as pulmonary vein atresia or progressive stenosis, hypoplasia of the branch PAs, irreversible end organ failures, progressive genetic or neurological diseases, and malignancy. So we do have a subset of post-chemotherapy cardiomyopathy. So when do you list them? So we would require a period of remission between 1 to 2 years, because immunosuppressants which are used post-transplant have a higher risk of tumor relapse. Certain relative contraindications would be active infections, GI or strokes, GI bleeds or stroke, medical non-compliance, history of depression, lack of family support, financial burden, substance abuse, all play a very important role. So now let's come to the transplant process. It can be categorized into organ functioning, immunological assessment, infections and vaccinations, psychological assessing the compliance, social and financial logistics, and definitely the listing process in India. In terms of cardiac assessment, first and foremost, it would be important to inform the surgeon what is the underlying anatomy of the recipient, especially in cases of complex heart defects, because the surgeon would have to sort of modify his harvesting techniques. Say in case of bilateral SVCs, where he would have to bore an extra length of the SVC above the innominate to help in the anastomosis. Certain other factors which play a role, previous history of surgeries definitely lengthen the ischemic time, and that's why you would have to sort of time the harvesting. Both the teams would have to go hand in hand, and there has to be some sort of coordination between the two teams, one who has gone for harvesting the organ and one who is prepping up the recipient. Presence of AP collaterals has an important role because it would cause volume overload on the new organ LV. And definitely a number of reconstructions, which I'm sure Dr. Ponen is going to address to in his talk. So hemodynamic assessment of the recipient and cardiac cath remains the class 1 indication, or it has been recommended by ISHLT that all recipients should undergo a cardiac cath prior to listing and annually. But how feasible is it for children who are really sick, especially the younger age groups between 1 to 2 years, who may or may not require general anesthesia during the process, and would we be tilting their balance? So it is a sort of a clinical judgment. We at our center are not very hard and fast about doing a cardiac cath in dilated cardiomyopathies unless we think that it is safe. The PVR cutoff, as I mentioned before, it has been standard that a cutoff of 3 be being used for adults and 6 for children in most of the centers. However, with the availability of devices and newer agents like prostacyclin analogs, by around 2015, there were 2 major studies which demonstrated that in children without CHD, elevated PVRI did not have a role on early mortality. We still do not know whether these cutoffs hold true for those with CHDs. Definitely, there has to be different cutoffs for patients who are palliated post single ventricles, and this requires further evaluation and further studies. In terms of functional assessment of children who are um, chronic stable heart failure, VO2 max is a very important tool. It gives us an objective identification of knowing when to list these patients. And there has been a standard cutoff of less than 12 to 14 ml per kilo per minute for those without beta blockers and less than 10 for those who are on ideal therapies and beta blockers. What about those with single ventricle? So healthy single ventricle population are known to have a lower normal average, which is reported between around 65 to 70% of the predicted values. So should we consider VO2 max of less than 50% of this value as a cutoff for single ventricle population to go on the list? End organ functional status assessment. So for the kidney, estimated EGFR less than 40 ml per minute per meter square has been taken as a relative contraindication. We have to remember that creatinine-based formulas for EGFR estimations sort of overestimate kidney function, because these patients with chronic heart failures are low on muscle mass, and their creatinines are spuriously low. So we use cystatin-based formulas, and there are scores which are available online where you enter the creat and the cystatin levels, and which sort of tells you, gives you an idea of the end of the kidney status before you put the child on transplant list. For the liver, there are 2 scores. There's the MELT score for those beyond 12 years, and the PELT score, the pediatric end-stage liver disease score for those less than 10 years. And there has been a very good paper, which is MELD XI, that is excluding the INR score, which has predicted early mortality in patients with liver dysfunction after heart transplantation. So whether do we need to list them for heart plus liver? That is a little bit of an advance transplant center which can take up these children. Immunological assessment, so just the basics of HLA. HLA are a set of proteins which are present on all cells. They distinguish self from non-self, and they will be present on the donor heart endothelium, on the donor myocardium. They are encoded by a gene complex which is present on chromosome 6, which is further divided into 3 loci. And the nomenclatures, there are beautiful papers which explain how to decode the HLAs. The numbers which follow the type of HLA gene usually indicate the allele group and the type of protein. So immunological assessment can be divided into knowing the HLA type of your recipient, and definitely abiotyping, knowing whether your recipient is already sensitized and there are antibodies against HLA, and definitely cross-typing between the recipient and the donor once the donor is available. So there are different tests. The most specific one is a NGS, or the next generation sequencing. This is just an example of how the report would look like. It would include a number of alphabets and numbers which tells us the type of HLA proteins present on the recipient. PRA, or panel reactive antibodies, these are the number of cytotoxic reactions of recipient serum against lymphocytes from a panel of donors. So for example, if a recipient has antibodies against A2 antigen, and your panel, in your panel, 50% of the donors contain A2 antigen, so your PRA would read as 50%. These antibodies are further identified with the help of Luminex platforms. They give us the single antigen bead assay, gives us the most accurate. It tells you the type of antibody which is present within the recipient against which HLA protein. So this is just a screen. This is what is the report would look like. This is a screening report, which is telling you the MFI, or the mean fluorescent intensity. That is the strength. It just tells you the strength of the antibody. It does not tell you about the pathogenicity, whether that antibody is going to be cytotoxic to the donor cells. So our cutoff of our labs is usually more than 1200 to maybe 2000. So less than 2000 MFIs antibodies are tolerable. When we say that your recipient is already sensitized after doing the screening tests, we want to know what kind of antibodies the recipient holds. So we have to test him further for identifying the type, knowing the strength, and the potential pathogenicity, or whether that antibody has complement binding ability. A PRA cutoff of more than 10% is often considered as sensitized patient in most of the centers. However, this varies from center to center, and there are some centers who hold 50% PRA as sensitized patient. I'm not going to go into the details of cross-matching, but the principle would be to assess compatibility between the donor and the recipient. We in India do not have the luxury of having known of the HLA type of the donor. So the principle of this is basically to identify whether your recipient holds antibody against the HLA type of the donor. We usually receive the results of these tests 48 to 72 hours down the line, and we do not have the luxury of doing virtual typing, but this is something which we need to work upon. So in virtual typing, we just need to know the HLA type of the donor, and we look for those antibodies within the recipient preemptively before an organ is taken. If you find that your recipient is sensitized, there are a number of desensitization methods or protocols which are available, which do nothing but either remove the antibodies, or you include IVIGs within the protocol, which would saturate the receptors, or you include agents which would target production. So you include agents such as bortezomib, which would be against plasma cells and reduce antibody production. So this is a protocol which I have borrowed from the Stollery Children's. Evaluating the recipient for latent infections is very, very important. So starting from active infections with regards to PICC lines, with regards to devices, latent bacterial infections such as MRSA and VREs, latent TB or tuberculosis, latent viral infections, because you do have protocols post transplant prophylactic regimens, and vaccination. So the 4-week rule for vaccination is still followed, wherein you do not want to give live vaccines. Um, Definitely post-transplant, because you are on immunosuppressants, and once a live vaccine is given, you do want a hiatus of 4 weeks before you do or go ahead with the transplant. This is the list of vaccinations which should be included within the protocol, especially the capsulated organisms and measles, which would be a live vaccine, and thus you would have to keep a 4-week gap before doing transplant. So assessing psychological status of the family will be very, very important. And the basic goal would be to identify families which would not comply to the post-transplant regimen, to the post-transplant medical follow-up. Coming to our setup, we have the two main governing authorities, the NOTO, which is a National Organ, Tissue and Transplant Organization, which sort of does not have a major hold, because until till now we do have states which define organ, who receives the organ, the listing purpose. So from where I come, the ZTCC, or the Zonal Transplant Coordination Committee, is the authority wherein we report to, who decides the listing, the ranking, and the organ delivery. An average cost of transplant in a corporate setup would be somewhere between 10 to 15 lakhs, and we still need a lot of work wherein the institutions can be roped in, government schemes can be roped in to help these patients. Preventing waitlist deterioration, as I said, is a very important aspect. And in our experience, since we started pediatric transplant unit in 2019, we had 2 waitlist mortalities in the initial phase. Both were DCMs. One was an 8-year-old and one was a 10-year-old, and it was quite frustrating waiting for an organ. So we started with home milrinone therapy, and we have had 4 patients on home milrinone therapy, of which 2 have received transplant. The longest patient has been for nearly 9 months on home milrinone. She's still yet to receive transplant. The last patient is a post-Fontan immediate failure due to AV valve regurgitation. She is still waiting for an organ on home milrinone therapy. They do pretty well. This is how we set it up for them. We have a PICC line in place, a portable infusion pump, and we have a nurse and myself who looks after telephonically with factors which are important from heart failure point of view. So pre-transplant evaluation involves evaluating the candidacy of the recipient to receive an appropriate organ. That should be the goal. Thank you.